Hello, I'd like to talk to you about testing for HIV, who we should test and how we should go about it. Perhaps a good place to start is a little bit of history. I can think back to 1996, which was the year when really effective treatment for HIV came about. Before 1996, the attitudes to HIV testing were very different from what they might be now, because here was a condition very serious, but to be honest, about which we could do very little. And I think our attitudes to how we test and who we test were conditioned during that period. And there developed a feeling that you really had to think very carefully about testing someone for HIV. You had to have a good reason for doing it, and you had to talk it through in great detail with the patient and ask for their agreement to it. Really, everything changed so dramatically in 1996. Since that time, HIV really has become a chronic illness which, managed properly, probably makes little difference to somebody's life expectancy or even to their quality of life. So the balance has shifted considerably, and now the issue is to try to normalise testing of HIV, by which I mean make it really just one more test that we do for certain indications. Now, who do we test? The great thing about HIV is that it can affect any system in the body, and regularly does. And very often, the very first sign that someone has HIV comes about, of course, because of an opportunistic infection. And your attention is focused on this patient with chronic diarrhea, with lymphadenopathy, perhaps with platelets down in their boots or whatever. And it takes a little bit of a leap of imagination to think this could have anything to do with HIV. But we must try and do that. We must all recognise in our particular specialty the particular ways that HIV might manifest there. And some particularly important ones. Two I'd cite, because to diagnose these might literally be life-saving, because the problem itself could be rapidly progressive. So we must not miss pneumocystis pneumonia. That's a unique presentation. I cannot think of anything else where you'll see a patient previously well, but for the last month or so they've had this dry cough, and they finally decided they should come and see you because they've started to become a bit breathless. Nothing else does that. That's PCP. And to diagnose that can mean that you prevent your patient going into overt respiratory failure, needing ventilation, and perhaps even dying. And there's another similarly urgent indication for testing, and that's if you think a patient has got, that you're investigating them for neurological problems, and the scan shows what appear to be possibly metastases, possibly multiple cerebral abscesses. Multiple cerebral abscesses are nowadays almost always toxoplasmosis, meaning the patient's got HIV. So there are two instances where it matters to save lives that we get this diagnosis and think HIV very quickly. And I'm thinking here unexplained weight loss, lymphadenopathy, unexplained, just simply bad skin, seborrheic dermatitis that won't go away. Other systems, confusion, new confusion, and odd neurological signs, peripheral neuropathy. All of these, absolutely every system, can be the point at which HIV declares itself. So, recognizing that we might see HIV in a whole wide range of situations and possibilities, we need to have a very low threshold for investigating it. How do we go about that? It's actually usually probably much more straightforward than you think. You've got a patient with pneumonia, and you say to the patient, you've got pneumonia, there are a number of tests we have to do in anybody with pneumonia. We might get a CT scan done, we'll do this and that, and we'll do an HIV test. And it's just one of a number of tests. And I assure you nowadays, if you put it like that, most of your patients will simply say, fine, if that's what you do, go on and do it. If, and sometimes they will say, hang on, why are you doing that? Explain the reason, and explain to them that knowing the diagnosis, if that's what it is, means that we can treat them effectively and prevent the illness progressing to a point when their immune system is damaged. And you might find it worthwhile pointing out that it means that we can stop them, if they are HIV positive, being significantly infectious to other people. So there are big public health implications to this as well. So always think about HIV, whatever specialty you're in, have a low threshold for testing for it, and thank you for listening.